So Mary's back, Head of Costing, Healthcare Pricing Office, and the patient level costing update is what we're getting next. Oh, and pick your step back there. We've a little step here for certain people.
It's like being the reader at maths.
Yeah.
Okay, so I'm going to speak to you this time about patient level costing, and some people in the room are probably very familiar with it, and some people have probably never come across it before. So what patient level costing is, in essence, it's a costing methodology that links the hospital expenditure to the hospital activity and calculates the actual cost of delivering care to an individual patient. So it allows costs to be assigned to each patient based on their care pathway, their treatments, procedures, staff time, their medications, their diagnosis from the hyperclassification, and any resources they consumed along their patient pathway. And it also allows the overheads of the hospital to be allocated back to those patients based on statistics like floor area, whole-time equivalents. So this is all the different areas of the hospital. It has your classifications, the types of patients. So as we said, that's the HYPE, and in the future it's going to be Lorna's URG system and Lorna's OCGs and Jerry's URGs. All of the hospital systems themselves, the likes of NIMS for radiology, the pathology systems or endoscopy systems, anywhere there's a patient contact. And then it matches that to the GL expenditure and comes up with a cost per patient, and the cost is per DRG. Benefits of and uses of it, and as Robert said earlier, really it's just cost collection unless it's actually used, is for the healthcare pricing office ourselves. It forms the foundation of ABF and pricing, and it provides us the data required to set the prices for DRGs, the URGs and the OCGs. It gives cost transparency. It's a much more granular level of costing than what we have at the moment with specialty costing. It allows hospitals to track their resource utilisation to their patients so you can see what things are actually being spent on. Nobody goes into Tesco at €50 and says, just give me food. They know what they're getting. It allows for value analysis and informed decision making. And as we said, it's closing that circle between just collecting more and more data, actually using it. And what actually drives the quality is the use, not just more collection. The history of patient level costing in Ireland is we started a pilot programme way back in 2010. At that point, people used to send their activity in to the supplier and they used to actually do the processing for them. So in 2014, we had our first tender and we bought Power Performance Manager, PPM, a piece of software that was rolled out at that stage to about 17 hospitals. And then over the years, it was rolled out to a few more in the Midwest and in Dublin Midlands. But over that time, we kept our specialty costing process, whereas that's going to be the change this time. This time, we've gone out to tender. We're about to go out to tender again for a full national rollout of PLC, and we're going to use it to replace specialty costing. And the reasons for that are specialty costing is very much an average cost per patient type, whereas with patient level costing, you get to the individual patient. So patient A comes in for hip, patient B comes in for hip, one costs 10 grand, one costs 8 grand. You'll see what fed into those variances in cost. Specialty costing ignores complications. DRGs actually aren't in it at all. It's just specialties, whereas the patient level costing is capable of capturing the complexity. Therefore, the specialty costing has limited insight, whereas there's much more potential for detailed analysis and a clearer understanding of cost drivers and insight and reporting with patient level costing. Specialty costing is also a very manual exercise. A lot of people in the room are familiar with it. It's 3 very, very unwieldy spreadsheets. And given all of the change in the system, they're actually very hard for us to change as well. There's a lot of new care pathways, virtual wards, surgical hubs. They're very hard to feed in, even new OCG codes as they come in. They're so big that you put anything in and it's just a domino effect. Whereas it's much easier to add a new code into a proper system. Specialty costing can't be used to set prices, so we can't go with that option. So we're going to go with the patient level costing option. And in the past, I suppose one of the challenges to patient, it's on the next slide, so I'll move on. So there have been challenges with the rollout. As I said, it rolled out to 17 hospitals in 2014, over 2015, 2016. It paused during COVID. There's about, I think, 11 hospitals submitted data for 2023. And I think we have 4 in at the moment for 2024. No, sorry, let's go back a year with that. Some of the challenges have been around resources. It is resource intensive, both from a people point of view and from an IT point of view, and particularly from an IP point of view, because you need patient-level records from basically all of your systems in the hospital. Another challenge, particularly on the people side, has been that we've had dual costing methodologies. And over the years, we've spent a lot of time trying to reconcile the results we get from the two of them. But they are two different systems. And internationally, everybody has gone with patient-level costing. And I think we're at the stage where we need to make a call that we go with the international best practice. As alluded to, the data extraction, the validation, the transformation, the loading it into PPM, that is something that's been a challenge, and that's something we've built into the tender documents, that we will put more emphasis this time on the integration with other systems, particularly with IFMS. Most hospitals, HSE hospitals anyway, will have IFMS by the time this comes along. And with where there's national systems, particularly the new endoscopy system, Solus, with NIMS, where there's a national system. It has a reputation for complexity. I'm not sure if the complexity is patient-level costing or healthcare in general is just complex. And because we have two processes, and specialty costing is the one that gets most of the concentration, we have struggled with getting timely data for price setting, which hopefully when we have one process, that won't be the case. The reporting, there have been challenges with the reporting. There's a suite of reports in it. There is a Power BI tool that we've set up that hasn't really had a massive traction. So that is another area we're going to look at for the tender, that there is a full national cost collection from the process, that there's full peer review, that there's a proper dashboarding system. And again, back to what Robert said earlier, there has to be management buy-in for all this, otherwise we're just collecting data. So the next steps for it, I went way over time earlier, but I'll cut it back now. The tender is due to be published very shortly. The documents are almost finalised. The next step will be to step up the whole project governance. Over the next couple of weeks and months. We will go out to the hospitals to do a readiness assessment. We did an IT survey back in, I think, 22 we did the last one, so it will be an expanded version of that, looking more at the accessibility of the data in the systems and also at the people and the resources and how people wish to roll it out in their regions. And then hopefully we'll have our, whether it's our new system or our current system, we'll have the tender completed towards the end of the year and we can start a phased rollout. The first hospitals in the rollout will be the current users, most likely. It will be a significant change management exercise, both for the Healthcare Pricing Office and for the system. The definitions of the roles and responsibilities, we're very much going to have to concentrate on the national cost collection, on setting standards so that it's standardised, so that it can be consolidated at a national level. But there will be a huge amount of engagement and communication. You're going to be sick of hearing about it. And extensive training on the new system and implementation support. Anyone who was involved in the previous implementation knows that we went out to each hospital and it was very supportive, hopefully. And there will also be ongoing support provided as there is now. And that's me for this time.